everybody. I'm Jayatri, Chief Bioscientist at the Franklin Institute. And thanks again for joining me for another conversation about the science underlying the COVID-19 pandemic. All right, we can get rid of the sign now that we're starting. So today I wanted to talk about some concepts that scientists are really looking for answers for that might help us explain some of the biggest mysteries around this disease, which is why different people seem to be affected with different severity of symptoms. Before we get into that though, I wanted to just quickly address two things that have come up in the news over the weekend, in the last few days. One I think is really interesting because we've had a lot of questions, especially on our kids Q&A that we did a couple of weeks ago, about how animals could get infected with the virus that causes COVID-19. And over the weekend, we heard some news from the Bronx Zoo that one of its tigers has actually tested positive for the virus. And even though they only tested one tiger, they think that up to 7 of their big cats might be showing symptoms of this disease. And so this is a little bit surprising because it's the first instance in which we've seen that wild animals, so not domesticated pets, might have picked up the virus from humans. In this case, they think that the cats were infected by one of the keepers who is an asymptomatic carrier of the virus. And so we don't know too much more about the biology behind how the cats are getting infected and what kind of response they're having, but it raises some new questions that I think are going to be really interesting to scientists as we start to track how the virus might be able to move back and forth between humans and animals. So it's something to just keep our eyes on. The other quick thing I wanted to just remind everybody is that we're hearing more and more in the news about the potential for a drug called hydroxychloroquine as a potential treatment for COVID-19. There was some renewed interest in this because of a small study that came out recently that seemed to show some promise. But again, I want to remind everybody that the clinical trials process by which we do randomized controlled trials to understand whether a drug is truly safe and effective takes time. And the studies that have been done so far just don't quite meet the standard for knowing whether they're safe and effective, either because there's small sample size or patients aren't randomly assigned or there's no control. And so there are controlled trials in progress. And so as people are going to the hospital to get treated, there's a real emphasis on making sure we're enrolling people in these randomized controlled trials to be able to get the most objective, reliable understanding as possible to know that how this drug might work. And if you're interested in learning more about that, we'll post a link in the comments to a blog and a couple of videos that we made with some partners in the bioethics department at the University of Pennsylvania, explaining the process and some of the decisions that are being considered right now as we're trying to develop drugs as quickly as possible for COVID-19. Okay, so let's get back to kind of the focus that I wanted to talk about today, which is some terms that you may have heard floating around recently about infectious dose versus viral load. So let me explain what those terms mean first. So the infectious dose is actually the number of viral particles that you're exposed to when you get infected. So in my little sketch here, in an encounter with another person, there are viral particles floating around in the environment, and if you inhale or somehow come into contact with that, then you have a likelihood of becoming infected. Now, one question that scientists are asking about the infectious dose is, what is the minimum infectious dose for COVID-19? What is the minimum number of particles, of virus particles, that it takes for 50% of people to get infected? And that's a standard epidemiological measure by which we categorize how infectious a disease can be. So the lower that minimum infectious dose is, the easier it is to transmit. Now, for COVID-19, we just don't know. we don't have evidence yet in humans. There are some experiments going on in animals, so both in mice and non-human primates, but again, we don't have a sense of how these experiments would then translate into humans. What we do know is that for other related coronaviruses, like SARS or MERS, that the minimum infectious dose for these other viruses is pretty low. It can be in animals on the order of hundreds of viral particles. So that might explain how this disease is spreading so rapidly. And if that's the case, then we have some concern more about the dose that you might be getting from a single exposure than building that up over time. So that's one question that scientists are really wanting to know the answer to. The other question about infectious dose is whether a higher infectious dose at the beginning, at the onset of your exposure, does that explain why some people get more severe symptoms? Now, this is a hypothesis that's based on flu. So when people have done experiments using the flu virus, they've actually exposed volunteers to different levels of flu virus and found that higher levels of the virus during exposure does in fact lead to more severe symptoms. Again, this is for the flu. So you might suspect that that the same might be true for COVID as well. Again, we've seen similar trends for SARS and MERS. And one mechanism that people have proposed about why this works is actually thinking about how the immune system responds. So we've talked a lot about how once you get infected, your immune system kicks into action to try and destroy the virus before the infection gets out of control. Now, this actually happens in two stages. Your first response is a non-specific response. It's kind of just throwing the kitchen sink at the virus. This is called your innate immune response. To just try and, it knows that there's some foreign invader, we want to try and get rid of it. The second stage of the response is one that we've talked about before. This is a more specific adaptive response, where now you're trying to produce specific molecules that recognize a particular virus and try and destroy that a little bit more in a more targeted way. So one idea about why a higher infectious dose might lead to a more severe response is that a higher infectious dose might kick that first innate immune response into gear at a higher level. And then that goes into overdrive and your body just can't recover from that as much. This is a phenomenon that scientists call a cytokine storm. So cytokines are molecules that are involved in that initial innate response. So again, potentially with that higher infectious dose, your cytokine storm goes into overdrive, and that kicks off a whole series of symptoms that you just can't back away from. So that's one theory about how infectious dose might be related to more severe symptoms. Now, let's contrast that with a second term that we call viral load. So remember that the infectious dose was the number of viral particles that you are exposed to. Viral load is kind of the inverse. Viral load is once you've already been infected, how many particles of the virus are you carrying inside? And so this is an important question because scientists are wondering whether your severity of symptoms is related to your viral load. So if you have more copies of the virus in your body, does that correlate to how bad your symptoms are? Now, what's interesting is that just because you have a higher exposure doesn't always mean that you have a higher viral load, because there are possibilities in terms of how different people's immune response can deal with an infectious dose. There might be, for instance, some genetic variation. You can have genetic variation in that ACE2 receptor. We've talked about this before. That receptor is the receptor in your airways that actually binds the virus. So if there's variation in the shape of that receptor where the virus just doesn't bind very well, then maybe your symptoms aren't so bad. Or if you have genetic variation in how your immune system responds, then maybe you have a chance of getting symptoms that aren't so bad. I'm going to pause because I think we've got a question.
2, actually.
Great.
So number 1 is, do only big cats get the virus because no other animals have symptoms and have tested positive for it?
Okay, so let's backtrack a little bit and come back to that question we talked about at the beginning. So the question is, how do we know that there aren't other wild animals that have it? And to date, this big cat is the only one that has been tested in captivity for having this virus. Now, scientists have been looking in other populations of wild animals, especially in China where the virus originated, to try and see where the virus might have come from. And as we've talked about before, bats seem to have the copy of the virus that is most closely related to what we see in humans. But we think that there are probably other types of animals that might have been kind of mediated that pathway from bats to humans in between somewhere. What's the second question?
Okay, so do animals have the same symptoms as humans?
Also a great question. So the reason that the zookeepers at the Bronx Zoo were wondering about this is because the cats seemed to be coughing and had a reduced appetite. And I am not a cat owner, so I don't have a lot of expertise with cats, but I don't think cats cough very often. So this would kind of tip them off that there was something wrong. But we don't have a good sense of, how the biological progression of the disease happens in animals. And that's actually a good way to think about talking about viral load, is that because the virus may have differences in how it binds to animal cells versus human cells, even if humans are infecting animals with like these tigers, their viral load may not be as high because their genetic sequences are different. Their binding between the virus and the receptor might be different. So again, this interaction on an individual level is something that's really important for understanding the progression of the disease. So what we know right now about the relationship between viral load and symptoms in humans is kind of mixed. So we have some early data from China that suggests that yes, patients with more severe symptoms do seem to have higher levels of the virus that are detected in their samples. But we also have some data from Italy that finds no relationship between viral load and symptoms. But again, these are still very early studies, and there are problems with how we've designed these studies so far that suggest that we still need more evidence before we can understand. So for instance, in the Chinese sample used a very small sample size. On the other hand, in Italy, we're just not testing enough people that don't have very many symptoms to get that relationship between their symptoms and their viral load. All right, we've got another question.
Now that we're seeing antibody tests being developed in 8 strains of the virus, do people who have recovered from COVID have to worry about catching 7 additional strains?
That's a really great question. So let's break that down into a couple of different parts. So one question was about the antibody tests. So let's remember that an antibody test is looking at traces of your immune response to the virus. So this is different from the tests that are actually looking for the virus itself. So that antibody test can help us identify people who have recovered from the virus. Now, what we think is happening in terms of different strains of the virus is that these different strains are genetically different from each other, but not in ways that likely interfere or make a difference in terms of how they function in their interaction with your body. So we talked, had another conversation, I think last week, where we talked about the importance of genetic variation in the virus. And even though we expect to see genetic variation, accumulating over time, just as random sites in the sequence change, we don't often see those affecting the parts of the virus that are important for function. And so I would be surprised at this point if the antibodies that your body produces would be different from one strain to the other. So I think scientists are hopeful at this point. Again, we need to follow the data, we need to do more testing, but typically the type of evolution that happens in a virus that would change your immunity to it happens on the order of months or years. So we wouldn't expect to see that this early. Okay. So far we've talked about, one question being the minimum infectious dose to get infected. We've talked about how we want to know the relationship between infectious dose and symptoms, as well as the relationship between viral load and symptoms. Before I move on to the last question we talk about, we've got another question.
2, actually.
Okay, great.
So will this be a seasonal virus like the flu?
This is a question that keeps coming up and we just don't know yet. So whether or not viruses survive or whether they tend to drop off during seasons does have some environmental variables involved in terms of whether the virus is able to stick around on surfaces when it gets, for instance, hot and dry in the summer. But because this virus has only been around for just a few months, we don't understand it yet. So we'll just need more time to figure out how this is happening, especially as we study it in different parts of the world.
And then our second question is, can you remind us what are COVID strains?
This is a great question. Let's clarify that terminology. So a strain of the virus is essentially different versions of the virus that have changes in the genetic sequence. And scientists can trace the relationship between these different varieties based on where they see those changes occurring. One interesting website that you can go to track how scientists are figuring out these relationships, one we've mentioned before, is a website called nextstrain.org. That's run by a group of scientists in Seattle. And they're really interested in tracking these changes, not just to see how the virus itself is changing for some of these potential concerns about whether we'll be able to maintain immunity to it, but also trying to track where these infections are coming from. So again, how we're understanding these strains is by collecting samples of the virus from all over the world, sequencing their genomes, and then looking for these changes that tend to cluster different varieties of the virus. And you can use that as a way to trace how it's spreading throughout the world. So again, something that we need to be keeping our eyes on as this virus continues to change. So the last question that I want to talk about in terms of infectious dose and viral load is how we might start to look at patterns of viral load within a patient over time to understand how likely we are as individual people to spread the disease. Now, this is a question of particular interest because we're seeing so many people who seem to be asymptomatic, or as scientists are now thinking, maybe pre-symptomatic in terms of spreading the disease. So what scientists are now doing is doing time course measurements of viral load in people to see how the viral load is changing day by day. And what some of the early data from Germany and China are showing is that there are very high levels of virus that people are shedding out into the environment very early in the illness. And that these levels of virus are up to 1,000 times more than what we saw with the SARS disease back in the early 2000s. And so we need to keep doing these types of measurements to get a better sense of how viral load is changing over time within an individual. But it does seem like this pattern could help us identify when a person is most likely to be infectious. Now again, this is going to require testing a lot more people before they develop symptoms, because we'll want to be keeping track of how that viral load is changing early on. But understanding these types of questions is really important, not just in terms of figuring out how to treat people, but also in terms of some of the public policy measures we're talking about. So for instance, in the US, just in the last few days, the CDC has changed its policy to recommend widespread use of masks as people are going out into public spaces. And the rationale for that is, well, since we now know that people might be shedding so much virus even before they're showing symptoms, let's put masks on to try and lower the infectious dose. Let's take another question.
So this one is, can you quickly redistinguish the difference between infectious disease and viral load?
Yeah, so as we're talking about what impact these have, let's remind ourselves what the distinction between infectious dose and viral load is. So infectious dose is the number of virus particles coming in from the environment that can get you infected in the first place. And we talked about the minimum dose, the minimum number of virus particles that it takes to actually overwhelm your immune system and get you infected with more severe symptoms. In contrast, the viral load is how many virus particles you're carrying inside you once you're already infected, and that may affect then the number of viral particles you're releasing out into the environment. So essentially, infectious dose is what's coming into your body. Viral load is how much you're carrying and then potentially sending out back into the environment. So they're kind of a circle, if you will, of how the virus moves in and out of people. So the second aspect of understanding this that's important for public policy is being able to conduct better clinical trials. We keep talking about how it's important to conduct tests of different medicines to understand how they work. And it's important to know, especially when you think about viral load, how effective a medicine might be at different levels of viral load. So if you're only testing a medicine on patients who have very, very severe symptoms that might be related to the high number of viral copies that they have, then maybe the medicine just doesn't have a chance to work and it's kind of a wasted effort. Okay, let's take another question.
2, actually.
Great.
So, is there any new news on the A blood type developing worse system?
So I have not seen another study come out about the difference in blood type, but that would be an example of how individual genetic variation might be mediating how different people react to the disease. So let's go back to what we had talked about before. There are some observations in China that people with blood type A seem to be more likely to be infected with the disease, whereas people with blood type O seem to be less likely. And again, this was not a controlled study in which we could clearly eliminate other factors from being involved, but it was really intriguing. And so I think we're still looking for that answer. But it would be interesting to look at how that genetic variation in the molecules that kind of sit at the surface of your blood cells might play a role in determining in determining your viral load or maybe your immune response to the virus. What was the second question?
Is it relatively safe to walk around outside without a face mask, or should they be worn at any time leaving the house?
That's a great question too. So remember, if we think about why we're wearing face masks, it's to try and prevent us from getting in contact with as many particles or respiratory droplets, as scientists call it, coming from another person. So if you are just going out on your back porch, with your family that you're, coming into contact with 24 hours a day, there's no reason that you need to wear a mask. But if you're going out to the grocery store, if you're going out to the drugstore, where you may come into contact with people, even if they're potentially 6 feet away, anytime you're coming into contact with people outside of your self-isolation, it's a good idea to wear that mask. If you're going hiking by yourself in the woods, you don't need to wear the mask because you're not coming into contact with those viral particles. So that's really the important thing to remember. Okay, we got another question.
Is there any data on why people with diabetes have such a higher death rate than people with diseases like asthma? New Jersey just published data that diabetics are in the 40% death rate.
Yeah, so this is a really interesting and important question to look at. And the data that I've seen so far suggests that because diabetic patients often have higher levels of inflammation to begin with, it's kind of starting them off at a disadvantage. So then when that immune system kicks in at an even higher level, you're dealing with that going into that overdrive system. With asthma, because that can be more a more targeted response from the body, that often you are dealing with poor air quality or more environmentally induced symptoms. It's not necessarily that chronic level that people are starting with. Now, that's not to say that if you have ongoing problems with your asthma, and we've certainly seen cases where people with asthma have a harder time getting over the symptoms. But we don't necessarily see that same level of higher inflammatory response as baseline as we do with diabetes. But again, we still need to continue to do more controlled observations to understand all of these, what you may have heard this term called comorbidities, these sort of different underlying conditions that all interact with how your body is responding to the coronavirus. So that's a great way to just transition to the last point that I wanted to make, is that we're starting to think about how this phase of strong social distancing starts to tone down. What happens, or how do we start to move about our regular business again? How do we start to get back to our regular lives? And this understanding of who's carrying the virus, how likely are they to be infectious, all of these things will play a role in determining how we start to interact with each other again. So if we can start to think about places where we might be exposed to a very high infectious dose, say sitting in a crowded movie theater, okay, that means that maybe we don't open up the movie theaters right away. But if we look at places where we can control the exposure of high infectious doses, that maybe as we're already doing, controlling the number of people who can be in any one space, we can start to phase that in a little bit more. Once we have a better understanding of this kind of dynamic, we can also think about how we reduce those levels of high viral load for healthcare workers as well. We're seeing that because of that high exposure for patients who are infected, and with the techniques that doctors and nurses have to do within a healthcare setting, that they are very much exposed to the virus at these high infectious doses. So how can we maybe do a better job of keeping track of how much healthcare workers are getting exposed to, so that we can protect them better, not even just through better protective equipment, but also maybe like scheduling them so that they're not doing as many shifts back to back. So these are some policy decisions that I think everybody will be looking at more closely as we start to understand some of these variables a little bit, and start to think about how we move to the next phase of our society's response to COVID-19. Thanks again for joining me today. I'll be back again next Monday, but in the meantime, please continue to tune in to our Facebook channel. My colleagues, Derek Pitts, our chief astronomer, and Dr. Rachel Valletta, our environmental scientist, will be bringing you more live content this week. So stay curious, and we'll be here for you. Thanks.